All right, so the point is that we need to understand the aesthetic before we actually do the technical. I think he's gone over a lot of it. I'm going to introduce some of it, but not as introductory remarks. I'm going to do so in the course of the actual technical aspects, and then more explicitly at the end of the talk when I talk about how I look at the aging Asian eyelid. So the aesthetic that I want you to see here is not just the crease position, it's also the fullness of the contour, something that we usually don't talk about when we talk about Asian eyelid. I think the fullness of the contour is a very youthful, soft look, so I rarely take out fat nowadays. I actually just reposition it, only because I put a lot of fat back in, and we're going to talk about that in a moment. We're not going to dwell on the anatomy. I think Dr. Ahn has done an excellent job of talking about that. And then also, I'm going to go a little bit through my evolution of where I've come. And I really moved to the full incision technique. The partial incision technique that I was using was less extensive than Dr. Ahn's. It was a very abbreviated 1.5 centimeter incision. So Dr. Ahn's is more, well, yeah, no, 1.5 centimeters. Yeah. And so I really use a full incision technique today. What I was having some problems is really banking on the permanence of that suture holding for 3 to 4 months before it becomes a non-issue. But if it falls out earlier, you have a problem. And it's much more tenuous a hold when you're using such a small aperture. It's also harder dissection. It doesn't save me any time. What it does is save a patient recovery time. But in terms of some of the issues that I've had, I've just converted over to the full incision method. The pros of the full incision technique are simply that you can modulate fat, skin, especially when you're dealing with an older patient, and also there's a more tenacious fixation. But the real key with a con is that there is a much longer recovery. It really takes a full year before it looks absolutely fantastic. And I owe a lot of deference to my mentor, Dr. McCurdy, who's taught me these methods. I actually do very little modification of his technique, and I really do a small fold. I really rarely do a medium, and if they want a large fold, I'm not doing it. It falls so far out of my aesthetic that I just can't do it, and I'm sure someone else can do it for that patient, but not me. Let's talk about some of the basic pearls of understanding how to avoid problems as you proceed. The things that I've noticed is, for example, I like to give them actually a little bit of propofol just to knock them out very short time. So I have to do it in my OR, and I just like to basically knock out that edge for the first few minutes. And then I give them, I like to mix 50-50 Marcaine and lidocaine, maybe excessive, but I find that I use so little of this anesthetic that the Marcaine just lets me push forward past 45 minutes to finish my procedure. I always use symmetrical amounts of lidocaine on both sides, and I avoid threading the needle through so that you limit the chance of a hematoma and a problem. And also, when you fully expose the levator, you don't want the anesthetic to drip on the levator, because you can actually anesthetize the levator, and the levator will be dysfunctional, sometimes for even a few weeks. And that can even happen if you don't, even if you just bother the levator. Always ensure symmetry. Everything I do actually surgically is based on how I perform Asian eyelids, which is to work in tandem. One part of the procedure taking the skin out, then the other side, and progressing in that fashion. If you find you're having a lot more edema for some reason on one side, I help maintain symmetry by putting a little bit more local on the contralateral side so that I can read symmetry a little bit easier. In terms of safety, so you don't get levator damage, which is obviously devastating, the thing that you've got to find first is your fat. Your fat is your safety landmark. Once you find that, everything else becomes easy if it's in a clean virgin territory. And so I'll work in a small fenestration to find where that fat is and then open it up, the remainder. I'll show you that in a moment. The other little caveat is once you've found your fat and you've gone down to the levator, you think, oh, I've got my levator in front of me. A colleague of mine, Dr. Kim out of Korea, has really focused me in thinking about something called what he calls a pseudolevator. Essentially what that is, it's the posterior leaf of the orbital septum. There's that flimsy little sheet that's a grayish color. You haven't quite gotten down to levator. And you can just take a little tines and open, and you'll see that you're then all of a sudden getting that glistening white levator. And that's something to give you a little bit better, more tenacious fixation. So how do you do it? Basically, you're going to mark it out with the skin under tension so that you have a perpendicular angulation of the eyelashes as you're marking. I use about a 7 millimeter height, sometimes 8 millimeters, depending on what I'm looking at. And then just taking out about between 2 to 4 millimeters of skin, depending on what I'm seeing in terms of the dermatochalasis if it's older. I'm pretty conservative, and that's just showing you under retraction. Then you go ahead and raise, I put 1 cc of lidocaine with epi, it's 50-50 mixture of lidocaine with epi, 1 to 100,000, and then 1/4% plain Marcaine. And I inject 1 cc using this wheel technique and then massaging it with my fingers so that I don't really get a chance of, a bruise or hematoma, which is going to mess up keeping symmetry. As you go through the skin, you're going to see these little vertical arcades that are passing through. What you want to be careful with is just cutting through that. You're going to get a lot of bleeding. So once you've gone through the initial dermis, I see these little arcades. I stay on the side of the skin island so that I don't cause a cautery injury to the preserved skin, and then so that I can go through a little bit more bloodlessly as I get into the next plane. At this point, what I do is I like to actually excise a little bit of orbicularis, orbital septum. It's really hard to tell what plane you're in. You're just taking a little bit more of that tissue out, and I'm hugging the inferior edge where my fixation suture is going to be focused. So I'm just running along there and taking a few millimeters out. Then I go laterally, and I open up and have my assistant just blot down a little bit to help see that push and herniation of the fat until the fat actually herniates through. Take your time with this. Make sure you get the fat exposed. Then I go ahead and open up the remainder of the orbital septum and orbicularis fibers, just using a little tines and making sure that I'm elevated and safe off the fat. Then I'll go ahead and I'll just use cautery, because remember, you're taking not only septum down, but a little bit of orbicularis fibers, and you're going to get a little bleeding. So I go and just cauterize a little bit bipolar, and then I go and free up the rest of it just using scissors. So I'm just widening that aperture of orbital septum and orbicularis muscle until I get to the right plane. This photograph was taken over a year ago. I actually rarely, if ever, take out post-septal fat. I just don't find it necessary. I think a lot of what you're seeing in the anatomy is that the orbital fat has descended inferiorly due to the fact that there's no fixation of the muscle to the skin. So I just brush it aside. Now occasionally you get this exuberant fat. I'll take a little bit of it out, but not very much anymore. So I go ahead and like Dr. McCurdy does, I just take a 5/0 nylon, I run it, as these are external fixation sutures, as Dr. Ahn was mentioning. If you don't know what that means, it just means it's a suture going through the skin that will be removed at a week. The internal ones are the ones that go through conjunctiva that are buried, that stay there. And because it's such a tenacious fixation, you really just can put in 3 of them, and they will hold tremendously well. You put one through the mid-pupil, and then you go, what I like to do at this point is, instead of going vertically up, to maintain the position that I want, I go horizontally through with a wide bite through the levator at the point that I want to create my height of my fixation. And then I go back up vertically through the skin. So that's going to be my completion of the fixation suture for the levator to skin. And you want to create about an angulation of a perpendicular angulation of the eyelashes. It's going to look too high, and that's to be expected because of the edema. Don't readjust to make it look small. I'm going to show you and walk you through a year of edema so you can see that. And we're going to complete 2 more fixations in the same fashion at the medial limbus and then at a point between the lateral limbus and the lateral canthus. And that's a bit arbitrary, but just stay consistent when you're doing this. Then I close with a 7/0 nylon. Let me focus on something that I've devised. This is going to be helpful for people that do Asian eyelids and even those that don't, just to stay out of trouble. So I have divided the aging Asian eyelid into without a crease, with a crease, and with a man-made crease in the past. So how do we address this? We first look at without the crease. The natural temptation is just take some skin out. The real problem with this is because the post-septal fat is so low, you're going to still have a very narrow palpebral fissure. The patient may say, I don't see much change. And that's a problem. If you go back and say, I'll just take some fat out, I've seen the problem with that is if you go in the post-septal fat, you take it out without creating a fixation, you can have inconsistent fixation that you didn't even intend, and that's a problem. And so I really caution you to be careful with this. I'm going to give you some strategies of how to do this in a moment, but I use a lot of fat grafting to take care of this, or I counsel them about putting a crease in, but there's going to be recovery involved, and there's also going to change the look, and that may be something unacceptable to someone older, and that's important to understand. Plus, when I'm doing aging Asian eyelid, I like to do it under just light sedation, and it sort of is harder when I'm doing deeper sedation work. So I'll do that first, and then go ahead and then do the rest of my other work with facelifts and fat grafting and that nature. If you look at a natural crease, you go, oh, this is easy. This is easy, Sam. I can go ahead and just take some skin out. Well, that's true, but you remember the cultural element, as Dr. Ahn was alluding to, is you got to be careful in making that crease too high. If you make it high, it can look okay in a Caucasian. My aesthetic is it also looks bad on a Caucasian because I do a lot of fat grafting, but it definitely looks terrible on an Asian. So be very careful in just taking skin out or combining that with a brow lift because things don't look so good or potentially can look bad. How do I do it? Very conservative skin removal, and I almost always have fat to maintain eyelid position. Again, that won't make sense until I show you some before and afters. And then finally, understand this, is that the term westernization, I sort of subcategorize that and look at that as a time when it was highly cut and a lot of fat taken out back in the 1980s. And the thing that I'll tell you that oftentimes, sometimes you look at these patients, you go, oh, the crease is really low, and you know, they had this in the 1980s, but it looks weird. What is it about it? And what it is that brow thick skin has actually become ptotic and deflated, and it's hanging over, so there's a little tiny crease, but it looks completely unnatural, and you can't figure out why. All you've got to do is take a finger, lift it up, and you go, oh my God, she's got a crease that high, it just fell over. So be very careful in just taking skin out of that person, because you can actually unmask a prior result that looks bad. This is a lady where, again, it looks like an eye bag, it looks like a dermatochalasis, and all I just did was add fat around the eyes, cheeks, and jawline, and that helps balance it. There was no cutting. This is a lady where you can see she's got some of that orbital hollowness, and there's a double fold at that point. I did take a little bit of skin from the upper eyelids, but I went ahead and contoured it. So just, I challenge you to think not just about incisional heights, but also contour, because there are two elements of the aging process that we may not all the time look at. Complications, Dr. John's done a wonderful job. I'm not going to go through that. This is a partial incision technique. I want you to compare the recoveries of both. I don't do the partial, but this is 1 week out and then about 3 months out after just that small abbreviated partial incision, which I no longer do. The full incision work, this is a week out, and then this is about 7 months out. I do have a year, and I have not updated it. I apologize for that. The year is on my website. And this is a year out after the full incision technique. Again, no fat removal, just fixation of the crease. So I really just challenge you to be thoughtful about preserving ethnicity and be mindful about some of the pearls and pitfalls that I expressed today. I'm going to plug my book here, but there's a book that's also been translated Korean if you want to know more about how I think about fat contour being a component of the aging process, both for Caucasians and Asians. That's my other book. So I thank you for your attention. If you want to email me, ask me questions, that's my email there. Thank you very much.